Okay, we're at the top of the hour. I think we'll go ahead and get started. I know we always end up taking the full hour for the TxSUS session. So welcome everyone. Thanks for being here. Welcome to the first TxSUS session of the Texas Substance Use Symposium 2025 season. We're kicking that off. If you're not familiar with our TxSUS sessions, these are our webinars leading up to the symposium, and these are our opportunity to continue the conversation between the symposia. So we have a great topic today. We're going to talk about 3 different models for medication for opioid use disorder or MOUD delivery across rural Texas. We have some great panelists for you. A couple quick housekeeping items. You've probably already noticed everyone is muted. That's just so we can hear our panelists, but we want to make sure that everyone can engage with us. So feel free to put your comments in the chat box and your questions in the Q&A feature. And we'll take about 10 or 15 minutes towards the end of the panel to take questions from all of you. And if we have a chance intermittently throughout the panel, we'll be taking some of those questions as well. Next slide, please. All right, some of the formalities. We have no financial disclosures to report for this session. It probably implied, but the views and opinions of our panelists today do not necessarily represent the official opinions of UT Health San Antonio or our colleagues at UT Austin. If you're looking for continuing education credits today, you can scan this QR code. We will also be putting the link in the chat. And then we will bring this back up at the end of the session today. And like all of our educational offerings, these CE credits are free. So we hope they are helpful to you. And maybe most importantly, hopefully everyone is saving the date for TxSUS 2025. We're excited to announce we're going to be in El Paso next year, February 27th and 28th. We'll be right in downtown El Paso. Very walkable, lots of great restaurants. We hope many of you will join us in person. I know over 500 of you joined us this last year in person and another 400 online. So we're excited to have another good turnout. If you can't travel to El Paso for whatever reason, we will have the conference available virtually as we always do. But we're excited to be in the border region and also serve our colleagues in West Texas. So hopefully you'll join us. And please know like every year, there will be opportunities to partner with us in the event to sponsor an exhibit. So more information on that coming as we get a little closer to the symposium. All right, so I want to introduce our panelists, and I'm going to give them an opportunity to say more about themselves. But first, I'll just mention who they are and where they're coming from. So we have Fernando Lozano, Clinical Manager at the Association for the Advancement of Mexican Americans in Laredo, Texas. We have Dr. Ralf Lukner of Lukner Medical Clinic in Pampa, Texas, and Dr. Jake Mumm, Medical Director of Olive Branch Recovery, largely telehealth services, but also with a brick and mortar location in Denton, Texas. So as I mentioned, I want to give you each an opportunity to say a bit about yourselves and who you are in your community and your organizations. So we'll start with you, Fernando.
All right, I do thank you very much. So my name is Fernando Lozano. I'm a licensed chemical dependency counselor. I've been blessed with counseling to be a counselor for 24 years. I'm also a peer specialist supervisor. So I've dealt with different modalities, which is detox, intensive residential, specialized female programs, COPSD programs, CPS contracts. So I've been blessed for the past few years to deal with, different populations, different individuals, and different programs. So I do thank you for having me here. And for the past more than 2 years, I've been working at a methadone clinic, which is a medicated assisted treatment. So that's been a very interesting challenge.
Thanks, Fernando. Dr. Lukner, take it away.
Yes. Hello, I'm Dr. Ralf Lukner. I'm an internal medicine doctor who has sort of stumbled into office-based treatment with Suboxone. I'm in the Texas Panhandle, which is a rural, remote area. We have quite a few people in this area who, some of whom have problems with dependence on opioids and other substances such as methamphetamines and alcohol, of course, and a wide variety of medications are being used. We have been working with Be Well for the past couple of years, and one thing we were talking about before we got on is that treating chemical dependence or substance use disorders is a team sport. I mean, it's really a team that you need, and without Be Well, there's no way I could do what I do to serve my community and helping people get their lives back. There's so many people that want to get better, and the resources just weren't here until we opened this up and started doing treatment with buprenorphine. It's been an incredible experience. I mean, I'll see entire extended families. I'll treat someone, and then it's like my son also needs to be treated, and my brother, and sometimes we'll have like 7 people from a family that we're all having treatment together, and they're all recovering together. And then I've got other folks that have been on buprenorphine or Suboxone for decades, and they're doing very well. They really don't have any impairments whatsoever in their life anymore. So that's really what we're trying to do for a lot of folks here and for our community, to heal our community here in the Texas Panhandle.
Thank you, Dr. Lukner. And Dr. Mumm, tell our audience.
Hi, I'm Dr. Mumm. I'm a board certified emergency medicine doctor. We too stumbled into treating patients for their various addictions. We do a lot of telemedicine all across the state of Texas. So we're a little bit different, unique model. And so, yeah, brick and mortar in Denton, but a lot of telemedicine. And so we're happy to be here.
Thanks so much. I'm glad you're all here. So now we're going to do a little deeper dive, as I mentioned in our introductions, and as you all mentioned, you each use a slightly different model to deliver medications for opioid use disorder. So I thought we could hear a bit more about that, a little more down in the weeds, a little more of your day-to-day operations. So maybe Fernando, we'll go back to you again first. If you wouldn't mind telling us a little bit about the opioid treatment program that you have there in Laredo and what that sort of looks like.
So for ourselves, we have a methadone clinic, but we also have the ability to prescribe a buprenorphine. But because of the population we deal with people that have been using opiates for multiple years. So buprenorphine at times is not as effective compared to methadone. So, we use a combination of the medical model plus also a holistic approach to where individuals, they have to come in, they have to be screened and assessed by counseling staff first to make sure that they qualify for our program. And then afterwards, they have to go through the nursing department to where they're actually given labs, blood is drawn. And then, afterwards, they have a doctor's appointment to where the doctor takes all this information and then determines, what dose to start them off at. And then, mainly with methadone, they have to start them off with 30 or 40 milligrams, and then it's increased gradually in small amounts for about a month and a half, till a person reaches a certain level of stability to where it's going to go ahead and do away with the withdrawal symptoms from the opiates and also help combat the cravings as well. And then afterwards, the client has to attend counseling services, and that's going to help them become educated regarding obtaining coping skills. So therefore, they'll know how to regain back their lives, how to combat, this opioid use disorder, and become productive members of society.
Great, thank you. Let's go to you, Dr. Mumm. I know you're doing a lot of telehealth.
Yeah.
Tell us a little bit about your model and why.
Sure. Yeah, sure. Our model's very different. So we were essentially forced into a telemedicine model because we started during COVID. And so initially we were like, yeah, let's open up a clinic, open up a place. And then COVID hit and everybody was locked down. And, people's addictions didn't go away just because they're stuck in their homes. So we just moved forward with the telemedicine model, and it really took off. So I guess I'll just walk you through maybe like how a patient comes to us and what ends up happening to them. So they'll either email us or call us or something like that. And we will, if it's an email, we reach out, get them on the phone and do an intake. We'll do screenings and do intake with we call them our front desk ladies because I like to make quotes because it's like there's not, I mean, we have a front desk, but they're not always they're at their house, you know? And so they call the patient, they get them screened, intake done, do all the usual paperwork, consents, and this is all electronic, right? So we send it to them and they sign it electronically. And then we get them on the schedule to be seen by one of our providers. And usually we're able to see the patient within 24 to 48 hours. And we see the patient within 24 to 48 hours. We call in their medications. That can be one of two ways. We can either call in their medications to their local pharmacy, or we can send it to them through the mail. And if we do the mail option, they receive it the next day. So the wait is not too long. These are all home inductions. These are not office inductions. We trust the patients to be able to titrate these medications themselves. I mean, essentially, they've been titrating, fentanyl and oxycodone and heroin themselves at home. So, we give them all the right instructions, and they do their home induction, and we get them lined up with our in-house counselors. So they'll do their counseling sessions on their phone as well. And we send urine drug screens in the mail. And so that's kind of how we do it. Our retention rate is really high. Patients seem to love it. So yeah, that's a very quick, patient comes in and is seen, and that's how we do it. Yeah.
Thanks, Dr. Mumm. How about you, Dr. Lukner? I know you sort of an office-based model. Tell us a little bit about what your model and practice looks like.
Certainly. We have a clinic in Pampa, Texas. Originally, we were just providing internal medicine care to outpatients for things like diabetes and heart disease. And then we discovered that there were a lot of people who were having issues with either pain medicine, controlling pain, and then on the flip side, having problems with the side effects from medications such as overdose, and even death, particularly when medications are combined, such as benzos and pain medicines. There are not really a lot of providers that specialize for this kind of treatment in this area. I'm the only one for at least 60 miles, but realistically, there are people who come as much as 100 miles away to our clinic. They find out about us, and they either visit our clinic. We also do telemedicine as well, simply because we want to provide access to our patients. I actually, commit one of the greatest sins that you can commit as a doctor, and I give my patients my cell phone number. They can actually call me, text me. We encourage them to communicate. We also have messaging through the clinic, of course. And basically, we try to provide a very accessible, welcoming environment. Through Be Well, we're able to provide people who have no insurance, no resources. We're able to pay for their buprenorphine, so they have no charge associated with their treatment. Generally, they come in the first time. There's a lot of paperwork to fill out. And then once they've done that, I interview them and also examine them, talk to them about what's been going on and what's going well and what's not going so well. Interestingly enough, although I'm focused on treating their substance use disorder, we very much get into making sure that our patients have housing, so we help them find housing. If they need an inpatient rehab situation, we work with Synacor in Amarillo, Texas, to get them into inpatient treatment immediately, regardless of ability to pay. We always work with our patients and make sure that they're getting the care that they need, that finances are not an issue. What happens is after the first day, we will have done drug testing. So we'll kind of see what they've told us that they're on and maybe what the urine shows. If there are discrepancies, we don't look at it as an adversarial type of thing. We look at it, well, you told me about these medications that you're taking, hydrocodone or THC, but I'm also seeing evidence of cocaine or methamphetamine. Would you be willing to tell me about that? So we really try to reach out to them and and be supportive. Not trying to make their life any more difficult than it is. And we've been very successful with this. We're growing very rapidly. And coming back to what I said earlier, it's a team sport. I couldn't do this without Be Well and their education and guidance. I've gone basically from knowing almost nothing about substance abuse treatment to really feeling very confident, and even having people who are on I hate to disagree with Lozano, but buprenorphine is pretty darn good. They're pretty darn good for managing cravings. And we also transition people from methadone to buprenorphine. If you have people that are on 100, 150 of methadone, that's not a small task. You really have to work very closely with the patient, sometimes bring them in daily. And we do that. A lot of it just comes down to caring. I mean, yes, I have 2 doctorates, but without a heart that really cares about the patients, it would be worthless.
Thank you all. Okay, so we heard a little bit about an opioid treatment program, a bit about what does MOUD look like in telehealth services, and then more office-based care kind of embedded in primary care. Let's talk a little bit more about impact. We know that MOUD is the most efficacious treatment for opioid use disorder. We know we see great outcomes for reducing mortality, yet we still see challenges with uptake in the provider community. We still see a lot of provider reticence and apprehension sometimes about prescribing these medications. And we see a lot of stigma in the community, right? I know a number of us have had offline conversations about some of those challenges. So if you wouldn't mind each sharing, maybe an anecdote, a individual patient and how they were impacted. And then we'll talk more about your community as a whole. But anyone feel free to jump in with how you've seen your individual patients impacted.
I've got one. And this is interesting. This guy said, he said, if I had to walk into a clinic, I never ever would have sought help. And so for him, and this is not everybody, but for him, that was his biggest barrier to getting help, was actually walking in somewhere. And so, this is a patient that I've seen now for, I want to say 3 or 4 years, and he's now tapering off of his Suboxone. He's down to like 1 milligram a day. And so he's doing really well. But for some patients and our population, they're very thankful that they can receive this kind of care with telemedicine from the comfort of their own home. And so some patients are, truckers, and they're always on the road, they're driving around. And so it's just hard for them to be somewhere all the time. And then even homeless patients tend to have cell phones, which is something I would not have expected. So we've been able to see, patients under bridges and, call it into their local pharmacy and get them taken care of. And so those are a couple of patient stories that stick with me.
How about you, Fernando? I know you mentioned earlier, buprenorphine may not be the best option for every patient, and for some methadone is going to be a better choice. Tell us a little bit about some of your patients that have benefited from your methadone services.
So with methadone, what we've noticed, for our patients, even though, for them reaching a stable dose might take about 2 or 3 months. But, once they get to a stable dose, what we've seen is like an 80% success rate in them stopping the opiates. They don't stop the other drugs, but they stop the opiates, which is the primary reason for coming into treatment. So that has helped us, but whenever we have patients that are still using other substances, so then this is where we have to take a collaborative approach and start referring people into detox and intensive residential services with their methadone. So this is, a very unique approach and a very successful approach that we've been doing. So, and clients, for the most part, they've been receptive, some of them, for actually, being allowed to go into detox and residential with their methadone.
What about you, Dr. Lukner?
I actually have a couple of questions for Dr. Lozano. So it was somewhere along the line, I learned that you had to be a federal clinic in order to offer methadone for treatment for substance abuse disorders. Is that true? Are you somehow a federal clinic? And then also, Do your patients have to come every day for their methadone, or do you prescribe them a certain amount?
So yes, we did have to apply for a license with Samsung with the DEA. So yeah, we are licensed to actually have this highly regulated narcotic medication. So clients, we are an outpatient program. So they do have to come in on a daily basis. They're provided a take-home dose on Sundays because we close on Sundays. But some clients, once they start abstaining from the opiates and other substances, they start gaining a takeout like every 3 months. So that's actually part of the regulations. There's an 8-point criteria that they have to qualify for. So we have some clients that actually only come in once a week. And they just come and pick up all their doses for the week and they take them home in a lockbox. We have some that actually come in only once a month because they've been actually absent and stable for so long.
Also, how long did it take for you to get, I guess, licensed? Is that something that any clinic can do, or what's involved in that?
All right, so that's a great question because it was beyond my time because, apparently here in Laredo, AMA has been here for about 27, 28 years. So I've only been licensed 24 years. So that's something that the previous the people that were in office actually partook of. But yeah, it's an application process you have to go through with SAMS and the DEA.
We can share more information about that offline as well, because I'm sure others will have questions. In fact, it might be a good future TxSUS session. But
Yes, so thank you for answering that question, because that's something that we may choose to do at some point. But right now we're doing buprenorphine. This is really something that any clinic, even clinics that just have nurse practitioners or PAs, they can get licensed to do this just through their DEA license. It's part of the process. Plus, their supervising physician obviously has to be on board with that. But it's actually very simple now. It used to be that you'd have to take, maybe a little course, 16 hours CME, and then apply to get this DEA license to maybe see 30 people. That's all gone now with the new laws. Any primary care provider can prescribe buprenorphine. And back to the original question, what about the stigma? That's actually one of the things that really breaks my heart the most about this. I mean, I work with patients who have substance use disorder, and I don't think of them as any less or inferior or to be pitied, nothing like that. I see it as any other condition, although it's certainly different from diabetes or high blood pressure. I don't think that's anything to be ashamed about, but my community doesn't convey that vibe. I have a lot of people who, when they find out that I've diagnosed them with opioid dependence, they're very angry. They feel like they've been, called out on adultery or some great moral sin. And I think that's one of the keys actually to getting more people into treatment, is to help remove that stigma, because it really is inappropriate. So I feel like there is a lot that can be done, but I don't have all the answers, certainly. I can change how people feel.
I'm glad you brought up the community piece, and that's a great segue. Let's talk a little bit about community impact. We've mentioned a few patient anecdotes. How are you having an impact in your community? What has been your community response, and how do you manage that on a day-to-day basis? Well, Dr. Mumm, let's start with you. I know you're more telehealth, so I'm curious.
Yeah, when we started just during COVID, it was kind of funny because I would call the pharmacy and they would say, well, you can't order this, electronically, or you're not within 60 miles. And the DEA had just changed their rules. And I remember having this conversation with this pharmacist, and she was like, who are you? And I was like, I'm Dr. Mumm. I'm with Olive Branch Recovery. I'm a board certified physician. I have a DEA license. And I can hear her typing in the back. She's like looking us up, like, what is this website? Made this fake website. And so finally, it was just, the uptake was slow. It was like hard for people to understand that, wait, things have changed. Things are different now. Like, you can see a doctor on your phone and get a controlled prescription, especially for opioid use disorder. It's not the same as getting your controlled prescriptions for, you know, something else. Like, this is a medicine that treats addiction. You should want these patients to be taking this medicine. So there was some resistance initially, but I think over the last, how long has it been? 4 years since COVID started. People have really taken to it, and I mean patients and pharmacies, they really seem to understand the model, and we still get a little bit of pushback, but it's funny because the pushback is a lot of times like Dr. Lukner in like small towns where they're like, you know, this patient's just gonna get high on this buprenorphine, you know, we don't need to be giving this out. We've had people ask us, well, like, how long is this patient supposed to be on this medicine? And I'm like, well, I don't know yet, you know? And so there are areas of Texas, it seems like the more urban metropolitan centers are a little bit more understanding of this kind of model, and the rural areas are tougher. But that's good because we can reach those areas. You know, we can reach those rural areas, and we can move the needle maybe a little bit, you know. Some resistance that we still get is at the policy level. So for example, what a lot of pharmacies will say is they'll say, I don't know, it's not me, it's just a Walmart policy or a CVS or Walgreens policy or something. And so, you know, they'll put in these policies that say they won't fill a prescription if it's not within 60 miles or something like that, or 100 miles, or you pick a number. And I don't know if those are true. Like, I don't know how high level is this policy? Is it at the national level for these, you know, companies? But there's still some work to be done at the policy level. And so yeah, that's our resistance, I think, for the most part. Those are difficulties. But I think we're moving the needle some.
So with respect to our community, both here in Pampa itself and more generally in the Texas Panhandle, and I would say that our impact is not as big as I would like for it to be. Yes, we have a lot of folks who we've treated, but it's going to take more than just treating people to have a community impact. I mentioned the issue of the stigma and really kind of changing the culture of substance dependence and its treatment. I mean, having a patient who's diagnosed with this condition and then, you know, being just extremely angry with me about diagnosing them with this, even though, you know, that's something I have to do. I have to put an accurate diagnosis. I can't just say, well, you know, you just have pain. That's not what I'm treating with buprenorphine. So it's difficult to change people's minds. I can talk to them blue in the face about how I'm not judging them and I can treat them kindly, but that's not what they experience in many other clinics and out in the community. Also, the other aspect of this is that one point that Dr. Mumm brought up is, you know, how long do you have to take this medication? You know, is there a point where you're well and you don't have to take it anymore? And what a lot of the studies have shown is that for people who stay on the medication as long, you know, for longer periods of time, they generally have less relapse than people who come off of it and then unfortunately get into a situation where they're using again and have to start all over. So I think that it is an impact that we're seeking to make in our community, but I feel like until we really change the attitudes of other health providers and people in the community to where they see this as an opportunity to help a neighbor, a child, you know, a father, someone maybe that they haven't met before, but who's part of our community, and to really, you know, make a difference in somebody's life, rather than seeing it as a moral failing and, well, you know, you're weak and that's why you need to take medication. Yes, okay, you know, we have people who now have jobs, now have housing, but you know, maybe we've impacted 100 people and there are 17,000 people in my community, and maybe there probably a couple thousand people around that don't have treatment and won't seek treatment, won't come to a clinic, won't answer anything because they're so ashamed. And I think until we change that, we're going to have a lot of people that will not be reached. But I'm optimistic. Be Well is making a big difference. And we have these TxSUS SUS conferences, and if you haven't gone to some of the ones in person in Austin, and of course now we're going to have one in the southeast of Texas and El Paso, I encourage you to go because it's really eye-opening to see how people are changing their communities. We're still learning, but we will make more of an impact as time goes by.
What about you, Fernando? What about I know you all are well established there in Laredo, as you mentioned, almost 30 years in practice there. What impact have you had on your community, and how do you engage your community?
So one of the interesting things I came to find out when I started working for this organization again, even though we had been here or have been here in Laredo for 27 years, the actual knowledge of the clinic existing amongst the professional communities was lacking. A lot of people didn't know that we existed. A word of mouth from the actual substance using individuals was what was helping the referrals to come in. So once we started doing community presentations, attending coalition meetings, then the questions started coming in, and I could relate to the stigma that is mentioned, because one of the things that I at times would get is, so what's the point of just substituting one drug for another? And there's a difference. There's a difference between taking an illicit substance, a drug that comes with some criminality involved with it, compared to taking a highly regulated, prescribed legal medication that comes with counseling. So it's about educating the community to where it becomes more inviting, a little bit more accepting. So in the past 2 years, in having done that, the community has actually been more accepting of referring people to the methadone clinic. But also for the past 3 years, Laredo has been suffering an opioid overdose epidemic. So because going back to our previous conversation we had, fentanyl has become an epidemic here in Laredo because of the cartels and the use of fentanyl to cut some of the heroin to make it more potent. So, and then plus they started putting fentanyl on the different substances, people just started overdosing. So now, for the people that are opiate users, they have, a place to come to, even though there is a Suboxone program, but going back to where, you have to find the right treatment for, the right person. It's not, it's not a one treatment fits all. It all depends on a person's, biology and anatomy in reference to how it's going to affect them. So I think we're making a great impact as we're going along. The actual overdoses have started to reduce. So the sad thing is we've actually faced, even client deaths in our clinic.
We have an interesting question coming in from the audience that I want to take. And it's around the demographic population that you're serving. And again, you all have 3 very distinct models here. And this guest was curious about, age, gender, race, ethnicity, sexual orientation, and maybe any health disparities that you all are seeing. And maybe you could each take this one. Dr. Mumm, do you want to speak to kind of the patient that you're seeing?
Yeah, I really feel like addiction crosses all socioeconomic barriers, all racial barriers. It just seems to affect everyone. And so it's kind of, I don't know. I mean, if you took a sample of Texas, just of all people, that's what our patient population is like. Like we don't, I think, have any predominant races. Like we do have a predominantly low socioeconomic status, though we know that addiction does affect people with a lot of money and no money, right? But I think a lot of people that end up coming to us, because we do focus our efforts in rural communities, they're probably a higher population of lower socioeconomic status individuals. Disparities, I mean, I guess these are communities in which there is a disparity of addiction medicine professionals, people that practice addiction medicine that don't understand what you just said, Fernando, that it's not just a drug for a drug, right? And so, yeah, I don't know what else to say other than it kind of affects everybody, and we have a really good mix.
How about you, Dr. Lukner?
Yes, I think that what we see is pretty much what the makeup of our community is. We're most in our area. There are a lot of I guess you would describe them as white Caucasian people, it's heterosexual typically, but we accept everyone, and we have people who translate Spanish. I mean, we do this in our clinic as well. We try to reach out to all Spanish, English. Those are really the two languages that we see people speaking. We reach out to the Spanish speaking community. We reach out to a Black community, and also gay and lesbian, queer, everything. We not just for opioid use treatment, but for everything really, for medical treatment. And we feel very strongly that even people who don't have insurance should have access, and we're able to do that with Be Well, and we're very thankful for the state grant that makes that possible.
How about you, Fernando?
So for ourselves, the population we deal with, not so much, the population for Laredo, but the people we deal with are about 95% Hispanic, because of being a border city. So we do have, 5% maybe Caucasian, but it's mostly, the Hispanic population we deal with.
Thank you for getting to that audience question. I want to move a little bit into kind of lessons learned, a little bit more around your implementation. So we know that MOUD availability across Texas is still very problematic. We want to support the community in, building up additional services. And I'm sure many are kind of wondering how you all did this and what that looked like. So maybe we could kind of go around and say sort of the pros and cons of the model that you're using, and any tips and hints you might have around implementation and sort of what your startup looked like, if that applies. And maybe we'll go back to you, Dr. Lukner.
Yes, that's a very good point. Any model, like if you're doing office-based treatment, people who maybe don't have a lot of money for gas and they live 40 miles away or 20 miles away, they may not be able to come. And so there's some people that we really try to provide the access through televisits, as well as, for people who do want to come here, we have the office-based setting. And I think in terms of cons, I feel like Dr. Mumm spoke to this earlier, is I kind of expected to, once I had the knowledge that, there would be this long line of people lined up outside my office ready to get treatment. And that's just not how this works. Even after, we put a lot of effort into raising awareness of what we're doing, when we talk to people that could benefit from the program, they're very suspicious. They're like, okay, what's the catch? Well, if something is free, is it really free? Are they selling your information? Or is this really some kind of trick to steal your identity? Or we see it all in terms of concerns and worries, and it can't be overemphasized that you really have to persist until you have a lot of people out there say, you might want to talk to Dr. Lukner in Pampa, because he can't help you. So it's when they hear from somebody that they trust that things really start to take off. And we have several people promoting that, and we also use Facebook and Instagram and other messaging in our own website to really make sure that everybody has as much information as they need in order to come in and use our services. Anything you do is going to have pros and cons. It really comes down to the people. I wish that, we could all just take a month off and learn everything there is to learn about this. And it's really not feasible. I mean, if you've got to pay the bills, you're going to have to see people. In our case, primary care patients, but then also opioid patients. If you wait until you've got it all perfect, it's going to take forever. And even then, you will maybe have 1 or 2 patients because it's really word of mouth that gets you more patients to treat. And we have empty slots. I know that there are people out there that would like to get treatment, but they just are too afraid.
What about you, Dr. Mumm, this kind of fully telehealth model? What have been the pros and cons of that, or what lessons learned could you share around implementation?
Yeah, so when we started, I think lessons learned, I guess you have to build community trust. You have to build relationships in your community. And for us, that was like, because it was during COVID, it was 1 million Zoom calls, talking to your local MHMR, your local counselors, your local, churches, Celebrate Recovery, NA, AA, everybody, and telling them who you are and what you do. And hopefully something will stick. So like our first couple of contracts were with the local MHMRs, and, probably a lot of y'all know this, but a lot of doctors can be jerks, right? Like somebody might be looking for a new doctor, and if you're not a jerk and you know how to provide a specialty service, then they might want to bring you on and have you provide that service. So I would say like building those relationships, building trust, it does take time. It definitely takes time and effort, and you just got to keep pushing and pushing and pushing. And it takes a couple years to get any business off the ground. I mean, MOUD is no different, MAT is no different. Doctors' offices are no different. It's going to take a couple years to get things off the ground just before people understand who you are and what you do. And that messaging is very important. I would say the messaging was like initially a barrier, because you want people to understand exactly what it is that you do. And they have other people coming in and telling them all the time what they do. And so you have to educate and re-educate and re-educate and just hammer it in over and over, because, if you tell people 1 million times that you do opioid use disorder, they'll remember opioid use disorder. They might send you an alcohol patient at first, and then you just re-educate. No, we don't do alcohol. We do opioid use disorder. We do alcohol now, but we did it in the beginning. And then when you get that one referral, when you get one patient, you've got to knock it out of the park. You've got to just go above and beyond, hold that patient's hand. For that referral source, you have to give them closed loop communication. You want them to know that you're working really hard and you're trying to do the best job that you can. Because if you don't, then you just might never, ever get another referral from that person again.
What about you, Fernando? We know there's this national push right now around the deregulation of methadone, but tell us a little bit about what you've seen of pros and cons of an opioid treatment program model.
So the pros, what I've seen is we have made a difference in the community. So if we've been in existence for 27 years, out of those 27, 28 years, 24 years, or maybe 23 years, we had a 100 patient capacity. So within the past, 5 years, we've actually increased it to 400. Right now, we are actually serving for the actual methadone clinic about 340 patients. And the only reason we only have 340 patients is because we need additional counselors to be able to serve additional clients, because we can truly serve up to 400 patients. So the pros is, we are making a difference. It's definitely a needed service here in this area. Some of the cons that I've noticed is the approach needs to be changed, because we're an outpatient program. One of my intentions and one of the things I'm really want to work towards is us having our own detox program, our own intensive residential service, supported residential service, and also, recovery support services and then housing. So that way, we can actually get people, put them into detox, start stabilizing them on their methadone dose, and have them detox from all other substances. They reach a certain level of stability, put them into intensive residential services for about 60, 90 days with their methadone. So therefore they can get clean of all the other substances and they're stabilized on their methadone. Then afterwards, put them into supported residential to where they can get a job, stabilize employment, start actually stabilizing regarding their family dynamics, and then transfer them to outpatient services with at least, I'd say, 90 days of complete abstinence. So therefore, it grants them more of a success to where they won't have to go through this trial and error that we've been going through for many years, to where we just grab patients off the streets, bring them into outpatient services, but that's not the best approach. So, and then afterwards, hopefully give them, like supportive housing and assistance, vocational training. So all of that is in the works, but it takes time.
So kind of becoming this one-stop shop medical home model.
Well, it has to do with the continuum of care right now, because we actually rely on MOUs and wait lists and making sure that the people get into the service. And if they finish detox, we need to make sure that they go into the other modality without there being a lapse. And if there is a lapse and you have the risk of the person relapsing, now they can't accept them into intensive residential because the person relapsed. So they might have to go back into detox. So it creates this actual issues. But if we actually had a very, a swift transfer of care, a continuum of care to where it can be not so much flawless, but, where it can flow well, then I think we would have more success.
We're starting to get some great questions from the audience. I have more questions for you all, but I want to make sure we get to our audience questions. And I'm glad you brought up housing, Fernando, because one of the questions pertains to housing. So kind of thinking about your other services in your community, and I know Dr. Lukner, you mentioned a lot of your patients needing housing as well. How medication-assisted treatment friendly would you say is, say, recovery housing in your community, or different support groups? Does anyone want to speak to that, what that looks like?
So I would say that, I never like to say things that are negative, but I'm kind of a blunt guy. So I would say that there isn't any recovery housing in this area. What we do is we make it happen. So we sort of make housing where there isn't any. So we either work with the landlord to make an arrangement for somebody to have a place to stay, or Amarillo's the nearest big city, they do have recovery housing there. But that's actually one of the things that we'd like to have here, not just for opioid use disorder, but really for anything. I mean, I really don't like the fact that there are people living on the street who don't have a home because they don't have either a treatment for mental health or treatment for substance use disorder or just other issues. I think that that's one of the signs of a healthy society is when you can care for the least, the people with the least resources and the people with the most problems in your community. I think that says a lot, and we've got a long way to go, unfortunately. But we just don't take no for an answer. We work with our patients. We help them with their resume. It's not the kind of thing that a doctor's office usually does, but it doesn't really take that much time, honestly. And when you do those little things, and you see a guy or a gal with a new job and paying their own bills, and just it's indescribable feeling.
Anyone else want to chime in on kind of mood friendliness or lack thereof in your community with other services?
I know in our area it could be highly improved because we do work with the homeless shelter, and at times they have like rapid housing. But even with the housing department, the housing authority, there's wait lists. You're talking about there's 100 people on the wait list. So it's kind of like, all right, so when is this person going to get their housing? So I know one of the approaches that I would be very interested in is Oxford Homes. I know, I used to work in the Beaumont area and we were really big on Oxford homes. So we could actually open up some of those here to where it specializes with having just a male Oxford home, a female Oxford home, and even a family Oxford home. That would be an option. But it's just initiative and getting, highly educated on how to get it started. And then just to keep the momentum going. Or unless there's actual grants that actually provide, housing programs, for substance users, that would be great. If you have anybody in the HHSC influencing, department, maybe they can shoot me an email, that'd be great.
Dr. Mumm, were you gonna chime in? I think.
Yeah, I feel like there is some resistance to MAT amongst 12-step, abstinence-based, and in these recovery houses. I've reached out to quite a few people, and it's a lot of that. We don't do that. Well, we don't do that here, and I don't know. I think maybe that'll change in the future, but I do see some resistance there. And even in 12-step programs, your local NA or AA, people might receive stigma from the fact that they're taking a medication and the person next to them isn't. And it's kind of, it's kind of sad. It's not the way it should be. I think there's like so many different roads to recovery, right? Like I love 12-step based programs. I love abstinence based programs. I love all of that. I love methadone. I love, MAT, whatever helps you get to where you need to be. That's great. But we've figured out over the last couple of decades, there is no one size fits all. Like it's not like you can just do one thing in your community and that's going to help everybody, right? And I'll be the first one to tell you that, telemedicine isn't for everybody. Methadone isn't for everybody. Office-based visits aren't for everybody. And so I love the representation y'all put together here, like so many different models, because man, like we were talking about before, it's a team effort. We've got to have so many different approaches to treating these patients. And so hopefully some of these recovery houses will become MAT friendly. I think it adds a layer, right? Like they have to have their medications locked away, and maybe there's a different level of security they have to address, and but these are definitely like doable.
I know we're running short on time, and there's some other great audience questions here, and I'm going to merge a couple of them because I think we'd be remiss if we didn't talk about these different models and what the financial model is, or how do you think about sustainability? So there's some questions coming in around your payers, and I know obviously some of you have grant funding, but maybe thinking outside of that. So there's questions about how you financially sustain your services and startup costs, if any of you have anything to share with the audience there.
So I can speak to that. It is actually very nice to have Be Well helping us financially, but starting out, and I know some of Dr. Mumm's partners, they speak to this also. You have to be prepared to sort of invest time and or money for a while. I would say at least a year or two. Because you're not going to have enough reimbursement to cover the program when you're first starting out. Just not. So in our case, we have primary care that we used to employ people, but then when we want something specific for substance use treatment, we just have to know that it takes a year or two to really get going. And now that we're further along, it's getting better and better. But this is people. I don't do this for the money. I do this because I have to do it. I can't just turn a cold shoulder to so many people and really the health of my community. So
I would like to say that yes, there is time and effort and money up front, but if you're a physician, if you're a PA, if you're an NP and you have a DEA, I mean, from a telemedicine perspective, like you can just see people and meet them where they're at. Like I saw a guy yesterday for free, and hopefully he'll get insurance next month and I can start billing his insurance. But these are the risks that we take to get this off the ground. You could see patients, you could be cash only. You could say, hey, you got $20. Like, you know, I think it's important for patients to sort of be invested in their recovery. So even if it's like $1, I like them to, you know, pay into it. That's not a sustainable model, but eventually when they get better, and if you can help people get better and you can build those relationships in the community and get that, like, I don't know, like people know that about you, that you'll go as far as it takes to help people, more people will come to you for help. And so, I mean, do we want to get into the question of how financially feasible insurance is for medicine in America? Like, it's tough. Like,
Another Texas.
so, like this is like a completely different session. What payer mixes do you need to be financially successful? I don't know exactly, but I would say that, like, don't let that be a hindrance to you if you feel like helping people in this area. Because like Dr. Lukner said, if I help a patient and they don't have money right now, like at least I'll go to sleep that night knowing that I helped somebody, you know? And hopefully next month they'll get a job and get insurance and come back if, you know, if we did a good job.
So if I may chime in very quickly, so, you know, I work for a nonprofit organization that's been in existence for 50 years. So for ourselves, it's just constantly making sure, you know, we continue with our funding source. We have state funding, federal funding. We're able to bill Medicaid, Medicare. We're actually venturing into also hopefully being able to bill private insurance. So it's just, you know, constantly looking at all different avenues for sustainability.
Mm-hmm.
Thank you. Well, I know we're just about at time, but I want to give each of you an opportunity for some closing thoughts to keep us on time. I'm going to say 30 seconds to a minute each. We'll start with you, Dr. Lukner, kind of closing thoughts from our panel today.
So I think the thought that I want to leave you with is what I've been saying all along. This is a team sport. Don't try to do this alone. Reach out to people who are already doing it, who've already made the mistakes, so you don't have to make them yourself. And really get ready to really make a difference. I mean, doing this is just, it's unbelievable the kind of difference that you can make in your community. It does take some time to get started, but I strongly encourage you to do it if you have any interest, or talk to people who are doing it.
What about you, Fernando? Any closing thoughts?
Thought to be, you know, treatment works, you know, always, you know, seeking, like the doctor mentioned, getting assistance from professionals is very helpful. And it actually makes an impact on people. And you never know, those people that you help, they'll turn around and help others.
What about you, Dr. Mumm? Final word.
I want to share a story from my ICU rotation in medical school. And it does tie in, I promise, in the end. Okay, so do you remember when people used to have heart attacks and go to the ICU and they'd be on the vent, and eventually we started cooling them, and we would cool them to like 32 degrees Celsius and make them really cold? Do you know where I'm going with this, Dr. Lukner? We would cool them, and then and these people started like getting better, and we're like, oh my gosh, we got to cool people. And so then they did a study where they compared 32 to 34 degrees Celsius and 34 to 36 degrees Celsius. So like 36 degrees Celsius, pretty much not cooled at all. So they compared the two, and they figured out that they had actually the same exact outcomes. The same exact outcomes, whether you cool them to 32 degrees versus 36 degrees. And so the question was why? Why do the cold and the not cold ones do the same? And the take-home point was because you tried, because you did something. Because even the patient that had a heart attack, they got stuck on a protocol, they got sent up to the ICU, the nurse was checking their vitals every 15 minutes, you know, they were doing all this stuff. They tried, and their outcomes were better, even though the numbers didn't exactly match. So I guess I would just leave you with that. As medical professionals, as doctors, as people in our community, man, if you just try, you'll make a difference.
Yes.
Thank you so much. Great closing thought. I know we are right at the top of the hour. I just want to thank you all for being here. We really appreciate it. All of our panelists, our audience members. I apologize, we couldn't get to everyone's questions, but hopefully we answered a few of them. And we will put our continuing education back up on the screen. But thank you all again. Thanks for being here and have a great day. We hope to see everybody at TxSUS 2025.